Thanks very much. I heard the news yesterday that UNESCO had started the clock on World Heritage status on Liverpool because of some plans about some new architecture around the historic buildings. And I was reflecting on this on the journey down this morning and just thinking about how actually that tension reflects a lot of the conversations that are going on around digital and mental health, which is we have our established architectures, we have our ways of thinking, we have our cultural icons in terms of mental health, our schools of thought. And in some ways, digital is transformational in that sense. It asks us to think differently. And I was reflecting on the similarities of, actually the solution is, for both of those tensions, both in terms of the real world in Liverpool and in that digital mental health conflict, is good architecture. Actually sensitively designed architecture, both in mind and in body, if you like, embodied, is probably the solution to that. So just hold that thought in mind when we think about kind of some of the work that's going on in digital mental health. So, and I suppose on that note, I wanted to start with this slide. Digital equals behavior plus technology. So often we can have conversations around technology that solely focus on the technology. We take a technologically deterministic point of view. The technology forms us as a culture. It informs us and it forms us as a culture. The opposite end of the spectrum is a social construct of technology, which is that we, as a society, as a culture, inform technology. And probably the reality is somewhere in the middle, but essentially, digital equals behavior plus technology. So let's not have a conversation that solely focuses on technology. Let's have a conversation about the human behavior that is behind it and is supported by that technology. That's how we'll get the best out of digital. Okay, so another reflection I'd have I've been in post roughly for 2 years. I've been working in NHS England on and off for about 3 years now. A lot of the thinking that goes on around technology is quite piecemeal. Mental health technology, or technology in mental health space, it's quite piecemeal. They try and bolt bits of technology on to existing care pathways. So using that architecture analogy, that's like building a glass dome on top of the LIVA building. You know, not everybody feels comfortable with that. Some people might think it's amazing. And actually that then leads to tension in terms of adoption and uptake and buy-in. Mostly from professionals, if I'm honest. It's professionals who really struggle with it. And one of the things I've been encouraging to do, and I was doing this down with the Psychosis network in the Oxford AHSN back in November, I was encouraging them to start thinking about pathways of care and digitally enabled pathways of care. So you're not just thinking about putting an app there or dropping a bit of technology and a live core there. You're actually thinking about how you remodel the entire pathway with digital as a core element to that. And I suppose this is our attempt nationally at thinking about the IAPT pathways, the improved access to psychological therapies pathway. It's a bit clunky. It needs a bit of work from a kind of UX point of view, we might say. But essentially, it maps the journey, thinking about how we can use technology in every one of those parts. And it's about enabling people to access digital through digital so that you can refer yourself digitally to a digitally enabled psychological therapy service, that you don't have to sign a bit of paper to get access to your digital therapy. There's a mixed message there. And on NHS Choices now, you should be able to find your local IAP service and find whether you can digitally refer yourself to that service. You can self-refer to IAP services. So that's already enabled. And then when you get there, you should be offered a variety of options around what a digital therapy looks like. And that might be simply using an app in between therapy sessions. So you're doing face-to-face therapy and you're using an app in between to record your mood or your sleep, or using maybe an app designed around your exposure therapy that you're doing for your anxiety, so it allows you to track the experiments you do in between those sessions, giving you that support that so often is missing, or that structure as well. Or it might be that you're doing synchronous text messaging therapy with a therapist at a time of your convenience, maybe at 8 o'clock at night, when normally the NHS, certainly day-to-day routine NHS services, are closed down, but you can access it when you want. Or you might be doing something a bit more blended in terms of you might have an online package that you're following, and every week you get a follow-up from a therapist who supports you in that journey. And I guess it's about having that plurality of choice that's important in a digitally enabled pathway. So what I'd encourage you to do is to go back to your places of work, your clinical settings, or working with the people who the clinicians in your lives, as it were, and think about how you embed digital from end to end, as Simon Stevens said, end-to-end digital, to help us think about that, to help us think about how we make it part of the architecture. And what are we doing to support that? So in yesterday, breaking news, I think there were more exciting breaking news perhaps for some people yesterday, but breaking news yesterday was NICE put up the news that we've been on hold with, thanks to PERDA, about the new program that we're launching to support the adoption of digital therapy. So this is going to look at specifically taking evidence-based programs that deliver computerized CBT, or internet-delivered CBT is perhaps the modern term, that is supported by a therapist at an interval. So you're not left to go and get on with it yourself. It's not self-help in that sense. It's guided self-help via a digital means. And we're going out to the field of researchers, of product owners, saying, come and tell us about the product that you've developed, show us the evidence, and if it's good enough, according to NICE, and NICE have come up with this way of appraising the evidence for these packages, then we'll support you in getting adopted initially in a dozen or so, and we haven't quite finalized the numbers, areas in terms of IAP services. And we'll be going out to IAP services asking them to show interest in taking on these digital products that NICE have given the provisional go-ahead to test. And then by the end of a 2-year package of evaluation, NICE will say, yes, we think this is approved. Well, we approve it, sorry. We don't think it is. We approve it. And that will then hopefully, that endorsement will encourage that adoption, give clinicians and patients that confidence to take it up. So that's one thing to look out for developing over the next 2 years. Okay, now I think a colleague from Merseycare is talking later about the local global digital exemplar. So I don't want to steal too much thunder because you might get more detail about the local area there. But the Global Digital Exemplar Program originally came out of Bob Wachter's review. So for those who don't know, Bob Wachter's an American physician who was asked by the NHS and the Secretary of State to come over and review NHS IT. He came up with the recommendations, one of which was to invest in those trusts that looked like they were further ahead than others, so they could go further and faster and show the way. And the initial announcement, much to the chagrin of many people in mental health, was for the acute trusts only. There was always a plan for mental health trusts to follow, and duly they have. So we've identified 7 trusts, including Merseycare, along with a few in the south, Northumberland up in the north as well, to be those GDEs for mental health, those global digital exemplars. And the problem with mental health was not a problem, but in mental health services, we don't necessarily have a model of digital maturity that's as evidence-based as we do in acute settings. So there's an American standard called HIMSS, and all the acute trusts need to get to HIMSS level 7. And I won't bore you with the technical detail, but essentially it means everything is digital. There's not a single bit of paper in the organization. We haven't got that standard in mental health. So one of the challenges for GDEs is they're going to have to work out what that standard is for mental health. And we'll be looking to colleagues in Merseycare, and I'm a fan of the work that Merseycare are already doing in terms of with Stanford Risk and David Fernley's work, etc. So, and hopefully that will allow us to develop these blueprints that we can then disseminate to what are called fast followers. So those are sites who look like they're ready to go, but haven't quite got there. So we'll give them a roadmap through that blueprinting that gets them further and faster. And so we speed up digital maturity in the system. And we're lucky in the sense that in mental health, we've only really got 4 major providers of electronic health records, which makes it easier in terms of doing that spread. In acute trust, you've got a few more than 4, probably in dozens or so. So it's an exciting program in terms of developing the architecture that we need in services to digitally enable those pathways that I was talking about before. Oh, wrong clicker. Technology. Okay, so I just wanted to briefly highlight some of the other programs that we're working on. So NHS.UK. NHS.UK, or NHS Choices as it's called now, is going through a revamp over the next few years. We're looking at making it a slicker journey, if you like, more like your, I don't know if people who do their tax return online, but more like you're kind of experiencing the kind of patient-identified or user-identified experience that you get with your tax return. And so you can access your GP records, hopefully in future. You'll be able to access potentially kind of local services through that citizen ID program. And the information will become much more concise, hopefully. In terms of the apps library, who's had a look at the apps library? Okay, I'd highly recommend you go and have a look at the apps library. We are looking for feedback on it. It's got a couple of mental health apps on there already, and we are waiting for a few others to be ready. And the CBT programs that are going to come out of that NICE program that I talked about earlier are also going to be hopefully going on there in due course. So we really like you to look at that. What I would highly recommend for developers is to go onto the developer website that's linked to on the apps library page and have a look at the 200+ questions that you've got to answer in order to see whether you can get on the apps library. People have been crying out, and every time I go to a conference or talk to developers, they're like, well, can't the NHS just tell us what it wants? Well, we've told you now, so get on with it. It's 211 questions, which won't surprise you if you work in the NHS. So we'll be, that will develop over time. We are still learning. It's an agile process. This is digital. So, look forward to your feedback on that. And the last bit, and I'm quite excited about this, I'm working very closely with colleagues in the National NHS 111 team, is about developing more intelligent triage around 111. So when you phone up 111 or you interact with 111 online, that you get a much more intelligent response, a much more responsive, sort of personalized, responsive action that comes out of it. So it doesn't feel like the person's just following a script. And in fact, in future, what you might get is an artificially intelligent response. So you don't have to wait to talk to a person, but it can help you solve the problem that you've got. And I think it's interesting listening to the last speaker that the critical part of that journey is that we know nationally, or there is some system to feedback nationally, what those services are available locally. And I see it time and time again across the country. And I was talking to an MP down in Cornwall who was trying to do exactly the same thing, is come up with a directory of service for their area. And actually, it's really hard nationally to keep track of what people are doing in terms of changing their commissioning of third sector or NHS services to offer those other, not just your GP or not just your IAP service, what else is going on out there. Particularly as a child and adolescent psychiatrist, parenting support or parenting courses just seem to come and go like wildflowers. They're in season and then they're gone, and you refer your patient and then the service isn't there. So staying on top of that, absolutely key. And I have worked with NHS Choices colleagues for a long time, and we've really struggled to get that, to build that communication, if you like. And I wonder if sometimes, and this isn't having a go, but I wonder if sometimes clinicians don't pay enough attention to the digital imprint that their services make, if you like. If you ever Googled your service, I Googled my service, and apparently I work in Greenwich, New York, not Greenwich, London. I wish. Okay. So think about communications. Now, there's a danger with all this digital hubris that people get left behind, okay? Not everyone has access to a smartphone. 80-odd% of adults do, but that's not everyone. Not everyone has access to broadband. So when we're thinking about launching a national program for computerized or internet-delivered CBT, one of the things we've got to think about, well, actually, is it the people that we're trying to reach don't actually have access to the internet to make use of it? And digital inclusion is there's a big program run with Good Things Foundation from NHS Digital, and my colleague Nicola Gill is leading on that, which is going to look at digital inclusion or digital literacy and access. And the Good Things Foundation used to be known as the Tinder Foundation, but apparently they had to change their name because it was linked to, unfortunately, another app. Okay, so this is a map that the Dot Everyone, Martha Lane Fox's organization did. The deep purple areas are the areas that are at risk of digital exclusion. I'm apologize because I meant to get the Northwest on the top of the map, but clearly my skills were lacking at that point, so there we go. So yeah, digital inclusion. And I've heard some interesting and sort of heart-rending stories of young people, where there's a local offer for digital, but they live in the middle of a blackout area when it comes to 4G, and they don't get, they've still got dial-up or, effectively dial-up instead of, fast fiber broadband. So it does have an impact. And I guess it's about choice. So do you use CCBT, internet-delivered CBT, for your populations who can access it, which allows you to remodel your workforce to direct them to populations who can't access the internet? And I think it's that kind of sophisticated thinking, rather than a blanket everybody gets digital, that we need to think about. Oh, wrong clicker again. I'll get it by the end. Okay. So I think the challenge going forward is moving from evidence. We've got enough evidence. We've had 20 years of evidence for internet-delivered CBT. Actually, the challenge is moving to adoption. And I think I talk to clinical leaders, and they say, actually, it's the workforce who struggle to get this. They struggle to make the change in the way that they work. It's challenging. It's challenging their architecture. And I think one message I've been trying to talk about is the fact that actually this is about the same old skills that you've developed as a clinician, but just using them to get to new worlds, to meet people in new worlds. So you're still having to connect. You're still having to have that understanding of what it's like to hold people in mind, to have the same language that allows people to think about how they have to help themselves, help the people around them, and maybe think about how their life could be different. So it's old skills, new worlds. Oh, I forgot I animated this. Sorry, apologies. Let me click it all out so you don't have to. Oh, okay. So this is not an endorsement of any particular computer product, by the way. So the core principles of the NHS don't change because of digital, but they get digitally enabled. So if we're thinking about regulation, it's about using digital and data to help us regulate more effectively. It's about using the processes of quality and safety assurance for technology. It's about using technology to improve access and patient outcomes. It's about, well, obviously using technology for interoperability and IT systems. And then the evidence base. So we talked about NICE endorsing those computer-based CBT programs, those internet-based CBT programs. So when you're thinking about digital, don't get boxed into thinking about the technology. You have to hold in mind all of those elements if you're going to be successful across that pathway. And finally, I suppose there is a future that actually quite excites me, in the sense that we could do some really cool stuff. Now, actually, I was thinking about this last night. There's a chatbot. This symbol's for a chatbot. The first chatbot in mental health, for mental health, was written in 1966. It was a Rogerian therapist based on the ELIZA program, okay? And apparently people found it quite good. They found it quite personable. And it was, the inventor was surprised at how people engaged with it. Chatbots are coming. Facebook has launched Woebot. I don't know if anybody's had a go at Woebot, but I would highly recommend that you play with these things, okay? So that you get used to them, because they're going to come along quite fast. Okay, virtual reality. We've been using virtual reality in mental health treatment for 20 years again. The guys in Spain and Italy have been using it for eating disorders treatment for about 15 years. And there was a very funny comment that I read, well, not funny, it was funny in the context of how we are now, that they were talking about one of the limits of virtual reality is that it costs £20,000 for a system. It doesn't cost £20,000 anymore, and that's why we're going to see a growth in it. One thing I'd really like to do as a child psychiatrist, there's a Google platform called Tiltbrush. Tiltbrush is a creative platform that allows you to paint in virtual reality. And what I'd like to do is get a family connected up in virtual reality, in Tiltbrush, and get them painting together as a way of connecting them again, getting them to experience things differently in that virtual world. I don't know if it'll work, but I'm super excited by playing that out and seeing what it looks like. So big data and apps as well. And this is my Minecraft office. And I would highly recommend that one approach to thinking about technology is being playful. Don't assume that you can't use it. So with a young person in an inpatient unit, child and adolescent mental health unit in London where I was doing my training, this young person was really struggling to engage with pen and paper. Week after week, he'd get frustrated, he wasn't interested, he'd walk out soon. I said, okay, how do you connect? Well, I play with my friends over Minecraft. I talk to my friends when I'm playing with them, with Minecraft together. Okay, let's do that. Why not? So we had a PlayStation on the ward. We started playing it. He taught me how to play Minecraft. It was fab. Really good experience. He talked a lot more, and he was so meticulous. It taught me so much about how this kid from a chaotic background actually had skills that otherwise we wouldn't have recognized. And I think the only way I got to that was because I allowed myself to play with the idea that actually maybe I didn't want to use pen and paper anymore. Maybe I wanted to play Minecraft. So have that in mind. Be playful about pathways, build the architecture, embed it in your practice, and think across all the systems. Don't just get boxed into thinking about the technology. Think about regulation. Think about safety and quality assurance. Think about all those elements. Okay? And I think we've got a pretty exciting journey ahead. I think by 2021, we're going to have some really cool stuff to play with. Okay, thanks very much.
Thank you, James. And there's so much going on there. I hope you'll agree it's really exciting. And I think the phrase end-to-end digital is a really good one for this work. So we need to sort of get to where people are, use digital in all its forms. And thank you for showcasing all that for us. No worries. Thank you ever so much. Thank you.